Thanks very much. And I'm presenting this on behalf of a large team of network investigators with PCIRN for the vaccine effectiveness theme. The PCIRN Adult Serious Outcome Surveillance Network was the major thrust of the vaccine effectiveness theme. We had two main thrusts during the pandemic first year of the program. One was the Serious Outcome Surveillance Network that I'm about to describe, and the second was participation with Dr. McGear's group about the influenza cohort study looking at vaccine effectiveness in outpatients. And Brenda presented a little bit of that before, and Allison is going to present a little bit after. But I'm going to talk about the vaccine effectiveness studies that was done in hospitalized patients. So we recognize that one of the gaps in the ability of our ability to monitor vaccine effectiveness was in this area in against hospitalization. So we set out to establish a network of hospitals, adult hospitals across the country, in which we could conduct active surveillance for influenza, both to better describe the burden of illness and the epidemiology of the disease, but also to provide an infrastructure for continuous monitoring of vaccine effectiveness over time. So we started out in 2009 with eight hospitals in 5 provinces. Those are the green stars, and you see that over time we're expanding the network now also into Sherbrooke, Quebec, and St. John, with hopes of another site soon in Winnipeg. Right now, at the time of this study, so in the 2009 pandemic, we comprised about 5,000 acute care hospital beds across the country. So we conducted, in those 8 sentinel hospitals, we conducted active surveillance for H1N1 in adults, so people over the age of 16 years of age or older during the second wave. And we collected nasopharyngeal swabs for PCR on all patients admitted with any diagnosis of respiratory illness, acute exacerbation of COPD or asthma, community-acquired pneumonia, unexplained sepsis, or cardiac or respiratory admission diagnoses with triage fever in the emergency room. Again, thinking that we may miss considerable numbers of cases if we used ILI symptoms and case presentations to determine who to test. And we did, in all sites, test them by PCR. So cases, this was a test-negative case control designed for vaccine effectiveness. So cases were defined as adult patients with a positive test for H1N1 influenza, whose admission was attributable to influenza or a complication of influenza. And then we selected 2 controls who were the next 2 consenting adult patients at the same site who had one of those admitting things that I said we would swab for, but who tested negative. And the test had to be obtained within 7 days of onset of illness. Vaccine effectiveness was estimated as 1 minus the odds ratio of vaccination in cases versus controls. We had initially intended to look at consider patients vaccinated if they'd received vaccine 14 days prior to the onset of illness, but as you've seen from other studies, we were handicapped by the fact that illness was peaking right around the time that the vaccine became available. So ultimately, we had pretty small numbers of patients who'd been vaccinated 14 days, so we looked at vaccine effectiveness at the day of vaccination, where you wouldn't expect, obviously, to see anything, and then at day 7. But we didn't have sufficient numbers at day 14. So this is just a general sort of snapshot of the cases over the time. We had 364 cases in the network, so about a quarter of the total number of reported cases in Canada were admitted to one of the SOS network hospitals, distributed across the country, as you see here. In terms of general demographics, about half were female. This data is very reflective of the data that's been published from other groups looking at the epidemiology of PH1N1 in Canada. Mean age was about 46. We had about 8% pregnant women, 2% of patients identified as Aboriginal. As you know, most patients admitted to hospital during the pandemic did have at least one medical comorbidity, and you can see them there. And about 20% of this cohort had received seasonal vaccine, and about 13% had received H1N1 vaccine. If you look at the characteristics of patients who were admitted with H1N1 in the SOS network hospitals, the mean length of stay was about 11 days, but you can see a considerable range there, and 6% of this cohort died. 29% were admitted to ICU and ventilated. So you can see that there was considerable complications associated with influenza in this group, and about 10% of them had an exacerbation of a chronic condition as a result of their influenza, if that wasn't what brought them into hospital. We also looked quickly at, Brenda described in much more detail the analysis looking at the predictive value of the ILI case definition in outpatients in the influenza cohort study. We looked quickly at that as well in predicting hospitalized cases of influenza, and again we saw similar results. So using the ILI case definition from the Public Health Agency would have identified only 34% of confirmed hospitalized cases of influenza during the second wave, with slightly increased sensitivity in the CDC definition and the World Health definition, which really only needs one symptom. When we were looking at vaccine effectiveness, we were handicapped by the fact that we could not identify controls for all cases, mostly because we had difficulty with wide spreads of age. So the controls tended to be older, the cases tended to be younger, so we couldn't match all of our cases with controls. But in the end, we were able to use 174 cases in the assessment of vaccine effectiveness. And you can see the comparison here. Cases were younger than controls. And were more likely to require ICU admission, and a few other small things. They were also less likely to have received influenza or pneumococcal vaccine. I'll just show you the estimates of vaccine effectiveness in the interest of time. In the univariable analysis, looking at the day protection from the day of vaccination, as you would expect, we did not demonstrate any vaccine effectiveness. But if you look at protection from 7 days post-vaccination, in the unadjusted analysis, protection with the vaccine effectiveness was 72% with a wide confidence range. When we adjusted for age, gender, current smoking status, and admission from a long-term care facility, the vaccine effectiveness estimate was 87% with a range of 30 to 97, which is fairly similar to reports from other jurisdictions. So in conclusion, we think that the PCIRN SOS network provides needed infrastructure for characterization of serious outcomes due to influenza and for calculation of assessment of vaccine effectiveness. As in the outpatients, 2/3 of cases of lab-confirmed influenza did not meet the FAC case definition for ILI. The implications of that, I think, is that if we really want to understand the burden of influenza in hospitalized adults, we should not be using ILI as a means to decide who to test for influenza, because we'll continue to underestimate the burden doing that. Also has infection control implications we could argue about later. But the 2009 adjuvanted H1N1 vaccine was highly effective in preventing hospitalization due to H1N1 in Canada. And vaccine estimates using a test-negative case control in this case in a sentinel surveillance network provided comparable results to those reported using other methodologies and in other jurisdictions. Thank you very much to all of the study monitors who worked very hard to get this up and running over the pandemic, and particularly to Ardith Ambrose, who's the national project manager, to the admin team at CCFB, because you can imagine that the coordinating of this many REB submissions and interinstitutional agreements in the middle of this mess was not a small task. And to the lab support group from PCIRN, as well as the clinical labs for providing the laboratory support that allowed us to do these studies. And of course to CIHR and the Public Health Agency for funding this network. Thank you.